May I invite Dr. Bindu Thampi, Professor, Department of Ophthalmology, Gogulam Medical College, for her talk on a curious case of droopy eyes in a toddler.
Good morning, all. So I would be presenting a curious case of droopy eyes in a toddler before you. A child, 1 year, 9-month-old child, presented with drooping of both upper eyelids, noticed by the parents 1 month back. There were no other associated symptoms like fever, seizures, headache. So a previous photograph, that is around 3 months back, was normal. So on probing further, the parents told that there was worsening of the ptosis towards evening, improvement after rest, but the birth and family history were unremarkable. The child had an chin elevated posture with bilateral upper lid ptosis. The ocular movements were full. So for a ptosis in toddler, we considered a myogenic cause, a neuromuscular junction disorder, neurogenic cause, any associated syndromes, or an acquired cause. In myogenic cause, there would be no fluctuation in ptosis, and neurogenic causes, there would be ophthalmoplegia or meiosis, and there were no features of any syndromes. So we narrowed down our diagnosis to neuromuscular junction disorder, that is juvenile myasthenia gravis or a congenital myasthenia, as the ptosis was fluctuating and fatigable. So we did an ice pack test, which turned out to be positive. There was significant improvement in ptosis. So we referred the child for a neurology evaluation, and there the parents revealed history of frequent falls, drooling of saliva, occasional difficulty in swallowing, decreased facial expressions, all in the past 2 weeks. But there was no history of shortness of breath. Child was active and alert. The central nervous system was normal except for the bilateral ptosis. Gag reflex was present, and palatal movements were also equal. So a neostigmine challenge test was done. Neostigmine 0.4 milligram was given IM with all due precautions in a pediatric ICU, which turned out to be positive. That is, there was remarkable improvement in ptosis. The child had expressions in the face. The nasolabial fold was there. So other investigations like blood investigations were normal. There was no thymoma on imaging. But on doing serology, the anti-acetylcholine receptor antibody and the anti-muscarinic kinase, anti-muscle specific kinase antibody was negative. So that led to a diagnostic dilemma whether it is a double seronegative myasthenia gravis. So in myasthenia gravis, 70 to 80% show a positive serology, or a congenital myasthenic syndrome. So we shall see about childhood myasthenia. It comprises around 10 to 15% of myasthenia cases. It could be transient neonatal myasthenia, juvenile myasthenia gravis, or a congenital myasthenic syndrome. Transient neonatal myasthenia occurs due to transplacental diffusion of autoantibodies from a myasthenic mother. So we ruled out that, and we were left with the other two options. So we shall see what they are. The juvenile myasthenia is an autoimmune disorder of the neuromuscular transmission, where there is production of antibodies against components of the postsynaptic membrane of the neuromuscular junction, and they target the acetylcholine receptor and muscle-specific kinase. So in generalized myasthenia, around 70 to 80% show anti-acetylcholine receptor antibodies, and in ocular myasthenia, it is 50%, whereas only 5 to 8% of myasthenia reveal MuSK antibodies. Purely ocular myasthenia may be seronegative in 50%, and it is 15% in generalized myasthenia. So double seronegative myasthenia gravis is an entity where the patient is negative for both the antibodies, but the clinical presentation is similar to myasthenia with acetylcholine receptor antibodies in terms of muscle weakness, distribution, disease severity, response to immunotherapy, and plasma exchange. So treatment options are pyridostigmine, immunosuppressive therapy, intravenous immunoglobulin, plasma exchange, and thymectomy, very rarely done in children in selected cases. So on the other hand, congenital myasthenic syndrome is a genetic condition. There is a mutation in genes that code for proteins. There is abnormality of the proteins involved in the neuromuscular transmission. So this also present with fatigable weakness and maybe ocular or generalized symptoms. But there is a positive family history, and muscle biopsy can show tubular aggregates. So genetic testing is crucial in the diagnosis. So here pyridostigmine may not be effective in all subtypes, and the definitive treatment is gene therapy with antisense oligonucleotides. So challenges we faced because of the patient being a toddler was that autoimmune myasthenia is very rare in toddler age group, whereas congenital myasthenia is seen in neonates to 8 years. But there may be overlap in symptoms, that is both present with fatigable weakness, doses, fluctuating doses, and moreover, the antibody was negative in our patient. So genetic testing became crucial for the diagnosis. So we can differentiate the two by a positive, good response to pyridostigmine and immunosuppressives in juvenile myasthenia, whereas the response will be poor in congenital myasthenia, and there will be a positive family history. So for our child, we started pyridostigmine and along with oral steroids, and there was significant improvement. And later on, we did a genetic testing which turned negative, and repeat antibody testing was advised after 6 months. So any child with myasthenic symptoms, after doing all the necessary investigations, serology has to be done. If it is seropositive, there is no doubt in diagnosis, it is juvenile myasthenia. But when it is seronegative, there is a doubt whether it is a double seronegative myasthenia or a congenital myasthenia. So we have to differentiate between the two as the treatment options are different. And if the diagnosis of myasthenia is missed, child can go on to generalized myasthenia and have respiratory complications which can be life-threatening. Thank you.
Thank you, Bindu madam.